Hi, good morning. Today we are going to discuss a very important topic, that's infective endocarditis, and this comes in one of the differential diagnoses of pyrexia of unknown origin. If it remains undiagnosed, it carries a significant morbidity and mortality, and that's why it is extremely important to keep always in mind. So, infective endocarditis is the microbial infection of a heart valve. That's the lining of cardiac chamber or blood vessel, or by a congenital anomaly. Both native and prosthetic valves can be affected. The most common causes of infective endocarditis are streptococci and staphylococci, but other organisms may also be involved. So, depending upon which tissue is involved, we have got the native valve endocarditis, which could be acute, subacute, or prosthetic valve endocarditis, which again could be acute, subacute. Then, depending upon the left-sided valves are involved or the right-sided valves are involved, we have got the left-sided endocarditis involving mitral aortic and right-sided endocarditis involving tricuspid valve and most commonly in IV drug abusers. Regarding the epidemiology, the incidence of infective endocarditis in community-based studies ranges from 5 to 15 cases per 100,000 per annum. More than 50% of patients are over 60 years of age. In a large British study, the underlying condition was rheumatic heart disease in just 24% of patients, congenital heart disease in 19%, and other cardiac anomalies such as calcified aortic valve or a mitral valve prolapse in 25%. The remaining 32% were not thought to have a pre-existing cardiac abnormality. Bacterial endocarditis is a serious illness and the case fatality is approximately 20% even with the treatment, and is even higher in those with the prosthetic valve endocarditis and those who are infected with antibiotic resistant organism, and that is also not rare these days. Regarding the pathophysiology of infective endocarditis, it typically occurs at the site of pre-existing endocardial damage. But infection with particularly virulent or aggressive organisms such as staph can cause endocarditis in a previous normal heart. Staphylococcal endocarditis or the tricuspid valve is common complication of intravenous drug abuse. Many acquired and congenital cardiac lesions are vulnerable, particularly areas of endocardial damage caused by a high pressure jet of blood, such as ventricular septal defect, mitral regurgitation, and aortic regurgitation, many of which might be hemodynamically insignificant. In contrast, the risk of endocarditis at the site of hemodynamically important low pressure lesions such as large ASD is minimum hardly seen. Now, infections tends to occur at sites of endothelial damage because they attract deposits of platelets and fibrin that are vulnerable to colonization by the blood-borne organisms. The avascular valve tissue and the presence of fibrin and platelet aggregates help to protect proliferating organisms from host defense mechanisms. When the infection is established, the vegetations composed of organisms, fibrin and platelets grow and may become large enough to cause obstruction or embolism. Adjacent tissue are destroyed and sometimes even an abscess may form. Valve regurgitations may develop or increase if the affected valve is damaged by tissue distortion, cause perforation, or disruption of a cardiac. There are plenty of extracardiac manifestations of infective endocarditis in the form of vasculitis and skin lesions, and may occur as the result of either emboli or immune complex deposition. Mycotic aneurysms may develop in arteries at the site of infected emboli. In fatal cases, infection of the spleen and kidneys and sometimes an immune glomerulonephritis may happen. And here in this diagram you can see a large vegetation in patient of virulent streptococcal endocarditis involving the mitral valve. Regarding the microbiology of infective endocarditis, if you see here in native valve endocarditis, and then here is the prosthetic valve endocarditis, and the third column is endocarditis in drug abusers. So in native valve endocarditis, if you see, then it is further divided into community acquired and the healthcare associated. In community acquired, it is the streptococci is the most common, and in prosthetic valve it's not so common. If you look at the staphylococcus can occur also in community acquired but much lesser than streptococci. In contrast, in the healthcare associated infections, it is predominantly staphylococcal and streptococci are much lesser. Then there are so many other various organisms, coagulase negative staph. Then we have got the Hackett organisms. We have got the gram negative bacilli, sometimes fungal infection with the candida, sometimes even you can find a culture negative endocarditis. The clinical presentation, there might be involvement of the heart, skin, and so many other organisms. Then there could be immune complex mediated injury manifestations and embolic. So in the brain we have got the cerebral emboli. In the eyes we have got the Roth's spots in fundi. In the eyes we can get the petechial hemorrhages on the mucous membranes and fundi, poor dentition and oral cavity, splenomegaly, we have got 30 to 40%, especially in long-standing endocarditis. Systemic emboli in the nail-fold bed causing infarct. You will have distal clubbing, splinter hemorrhages, and embolism in the periphery leading to the loss of pulses. There would be petechial rash, which is common. Sometimes embolism into the kidney leading to hematuria. In the hands you can find Osler's nodes. And in the heart you will find the valve involvement leading to the recurrent lesions and ultimately heart failure. Sometimes it affects the conduction system and can produce conduction disorders. So clinically, if the murmur is changing, one should always suspect underlying infective endocarditis. So varying murmurs, either new or changed murmur, should never be missed and always keep a possibility of infective endocarditis. Here are Janeway lesions of the toe as well as other embolic infarcts which you can find in the periphery. So clinical and lab features of infective endocarditis, if you look into the clinical features, fever is the most common, followed by chills and sweats. We have got the anorexia, weight loss, malaise, myalgia, arthralgias, back pain, heart murmur are common 80 to 85%, especially new and worsened regurgitant murmurs. You can find arterial emboli, splenomegaly, clubbing, neurological manifestations, the peripheral manifestations in the form of Osler's nodes, subconjunctival and subungual hemorrhages, Janeway lesions, and Ross spots, and petechiae. In laboratory manifestations, we have got anemia, leukocytosis, microscopic hematuria, elevated ESR, CRP. Sometimes rheumatoid factor is also positive, circulating immune complexes, and decreased serum complement. So the diagnosis of infective endocarditis is made again on Duke's criteria, the major criteria, and then we have got the minor criteria. In major criteria, we have got the positive blood culture, and second is endocardial involvement. In positive blood culture, either typical organism are grown from two cultures, or there is a persistent positive blood cultures taken 12 hours apart. 3 or more positive cultures taken 1 hour apart. Endocardial involvement is detected by echocardiography in the form of vegetations as well as the development of new valvular regurgitations. Regarding the minor criteria, we have got the predisposing valvular or cardiac abnormality, intravenous drug abuse, pyrexia beyond 38, embolic phenomena, vasculitic phenomena, blood culture suggestive of organism grown but not achieving major criteria, and of course suggestive echocardiographic findings. So patients with 2 major or 1 major and 3 minor or 5 minor have definite endocarditis. So you have to have a 2 major or 1 major with 3 minor, and if you consider only minor criteria, then there should be 5. So these 3 categories have got the definite endocarditis. And patient with 1 major and 1 minor or 3 minors have a diagnosis of possible endocarditis. And here is the echocardiographic picture, and you can see there is a vegetation as well as there is a regurgitation on the mitral valve. There is a vegetation leading to mitral regurgitation. Regarding the treatment, the medical treatment, of course, the antimicrobial treatment is of common causative organism in infective endocarditis is most important. And one has to remember that in infective endocarditis, we need large doses of antibiotics for longer duration. For streptococcal, we have got the penicillin G, and so benzyl penicillin intravenous we gave 1.2 gram 6 times daily. And then we have got the gentamicin, vancomycin. They are also given IV for 4 weeks. That's in the native valve, and in prosthetic valve they are given for 6 weeks. When you are combining penicillin with gentamicin, then these have to be used for 2 weeks. In enterococcal endocarditis, of course, you have to use ampicillin or gentamicin, vancomycin and gentamicin or other alternatives. And again the same principle, that in native valve at least for 4 weeks, and in prosthetic valve at least for 6 weeks. In a staphylococcal, we have to use IV flucloxacillin along with vancomycin and sometimes oral rifampicin. And of course, these have to be given for native valve for 4 weeks. A staphylococcal prosthetic valve, especially those who are methicillin sensitive, you can use IV flucloxacin along with gentamicin and rifampicin. And those who are methicillin resistant, you have to use vancomycin and rifampicin. Now, conditions for the short course treatment of endocarditis caused by fully sensitive streptococci as native valve infection, MIC less than 0.125 milligram per liter, no adverse prognostic factors as the patient doesn't have heart failure, aortic regurgitation or conduction defect, no evidence of thromboembolic disease, no vegetations more than 5 millimeter, and the clinical response is there within 7 days. Now, what are the indications for cardiac surgery in infective endocarditis? If there is a persistent heart failure in spite of medical treatment due to valve damage, failure of antibiotic therapy, that is the persistent uncontrolled infection, large vegetations on left-sided heart valves with echo appearance suggestive of high risk for emboli, previous evidence of systemic emboli, and of course the formation on abscess. The surgical treatment, which could be emergent, urgent, or elective. Emergent, that means it has to be done on the same day. Urgent, you can do within a day or two, and elective whenever it is preferred. So, whenever there is a valve dysfunction with pulmonary edema or cardiogenic shock or acute AR or MR or a rupture into the pericardial sac of an abscess, there is a emergent surgery. Emergency surgery is required on the same day. The urgent, that you can do in a day or two, valve obstruction by vegetation, unstable or dehiscence processes, aortic or mitral regurgitation with heart failure, NEHA class 2, 3 or 4, septal perforation, perivalvular extension of infection with or without new echocardiographic conduction system damage, and lack of effective antibiotic therapy. Whenever the vegetation diameter is beyond 1 centimeter but not urgent aortic or mitral valve dysfunction, you can perform in a day or two. And of course, elective, if the patient is hemodynamically stable, progressive valvular prosthetic regurgitation is there with valve dysfunction plus persisting infection beyond 7 to 10 days of antimicrobial therapy, and whenever there is a fungal endocarditis, you have to plan and do it actively. Endocarditis in old age, sometimes symptoms and signs are not very specific. Patient just presents with delirium, weight loss, malaise and weakness, and the diagnosis may not be suspected. Common causative organism in the old age are enterococci from UTI, Streptococcus galolyticus, it's a form usually comes from gut. And of course, one has to remember the morbidity and mortality of infective endocarditis in the old age is quite high. Regarding the prophylaxis of endocarditis, there is a lot of changes in the recent guidelines, and these are the only listed conditions which needs endocarditis, and not as before we used to think. That's a prosthetic heart valves, rare endocarditis, unrepaired cyanotic congenital heart disease including palliative shunts or conduits, completely repaired congenital heart defects during the 6 months after the repair, that is, complete endothelialization should happen, incompletely repaired congenital heart disease with residual defects adjacent to prosthetic material, and transplant valvulopathy. The antibiotic regimes for prophylaxis of endocarditis in adults with a high-risk cardiac lesions: standard oral regime of amoxicillin 2 gram oral 1 hour before the procedure. Those who are unable to take oral, you can give 2 gram IV or IM within 1 hour before the procedure. And those who are allergic to penicillin, you can use clarithromycin or azithromycin 500 milligram oral 1 hour before the procedure, or cephalexin 2 gram or clindamycin 600 milligram. Those who are unable to take oral and penicillin allergic, you can use cefazolin or ceftriaxone 1 gram IV or IM, and clindamycin 600 milligram IV or IM. So that's all about infective endocarditis. One should always keep in mind, especially patients who are predisposed to it and presenting with prolonged fever, because if it remains undiagnosed can cause serious morbidity and mortality. Thanks for kind attention, and thank you.